Welcome to another episode of Judgment Date. As you know, we've been tracking a whole range of issues, but particularly the issue of COVID and its effect on us, both the medical, the legal, the economic effects, which we've had to encounter over a year. And today, particularly pleased to welcome Professor Marc Mendelson, who's Professor of Infectious Diseases at UCT, to talk to us about some of these issues, which are clearly creating great anxiety amongst people. So Marc, thank you very much for joining us. I wonder if I could start by asking you, we seem to be in a sort of lull at the moment. Is this the lull before another storm?
I fear so, yes, but what isn't clear is what that storm's going to look like. So if you look at the history of the epidemiological curve in South Africa over the last year, we clearly had our first peak, our first wave, and then we had a couple of months in between the second wave, and now we're starting perhaps the first month in that lull between until possibly the third wave. And this time, of course, it's likely to coincide with the winter season, which is traditionally the viral respiratory infection season for the common cold, influenza, and everything else. So I think if one was a betting man, you would put the likely third wave to come around May, June. Of course, this, although the effects of coronavirus are predictable, it's unpredictable in so many ways. And so, we continue to learn, and it continues to teach us things about not only itself and our reaction and actions to it. But I think that because of the delays in vaccine rollout, and even if we had started vaccine rollout a little bit more aggressively than we have, we probably would still be looking at a third wave. And even countries
and would that third wave, in terms of what you're thinking, would the third wave be as as devastating as the second wave was?
So the second wave was driven very much by the variant, which was more transmissible. And so we had this massive force of infection, and we saw higher peaks. And so the real damage, was done obviously within the health service and our ability to be able to cope and to treat people. And so just the sheer force of infection, the numbers, really created the major problem. That's one of the great unknowns now. Do we have enough immunity within the population, plus the small amount that we're getting from vaccine, and possibly, more if vaccine rollout is accelerated, to not see that large peak in the third wave? Or will we see another large peak? Will the virus change again? And it's continuously changing, but will one of these changes or a number of these changes stick and give it an evolutionary advantage? So it could be more devastating. It might not be. It's really difficult to predict.
Can I just ask you as a layperson, everything I ask is the layperson, so what am I talking about? But the idea that more people have been infected, obviously, than let's say when we started this business, that's pretty obvious. Does that in fact, we probably at a fairly significant sum of people have been infected, either wave 1 or wave 2. Does that have an effect on then what occurs? Are we getting to a situation where we haven't got herd immunity, but we've got sort of more and more of the population having already must have some antibodies?
Yeah, so absolutely, and not only antibodies, but it's an immune response even greater than antibodies, which plays into the severe versus non-severe. But to answer your questions, yes, absolutely. We know from some seroprevalence studies that have been done from the second wave that some areas within South Africa where there's very high force of infection, very high density infection, has seroprevalence in terms of immunity, antibodies up to sort of 60% in those populations. Of course, what we don't know is how, some of those will have been from the first wave. We know that vaccine, at least from the vaccine, the duration of protection is going to be probably at least 6 months, and probably much more than that. the protection from natural immunity, having had SARS-CoV-2, again, is likely to give protection. It will depend slightly on whether you had more severe disease or maybe asymptomatic infection. The idea is that your immune system your immune response may be stronger and more long-lasting the more severe COVID that you had, rather than asymptomatic. But again, a lot of this is unknown because obviously we're dealing with something which we've only been dealing with for 16 months. But yes, I think that the critical issue is that that this isn't universal and homogeneous across South Africa. This is going to be different in different pockets and in different parts of the population. So there may be parts of the population where the density of infection and the force of transmission was not so great. If public health measures are not adhered to, if vaccination rates are not gained, fast in those populations, and in populations where perhaps immunity starts to wane, you may see a high force of infection in those areas as well.
So let me ask you this, in relation to that, obviously all sorts of people got COVID right through this period. So if I haven't been infected with the variant, does that mean I'm more susceptible now to a possible second infection?
Well, the findings that we have is that for people who have who were infected with, in the first wave, with what we call the ancestral virus, in other words, before the B1351 variant, those people are, have less of an immune response in terms of an antibody response against the variant strain. If you took their blood and tested it against the variant strain, they wouldn't neutralize as well as against the initial ancestral virus. So in other words, people that have been infected first time round with the non-variant are able to be infected with the variant strain, and potentially other variant strains that are continuing to evolve in the population. So it's not foolproof. And yes, if you haven't had the variant strain before, then you are more likely, I guess, to be, one could say, to be infected with, to get a second infection with the variant strain.
How would I know? How would I know whether I had the variant strain?
Well, firstly, our sequencing of the viruses during the second wave and around that time when it started and to now, show that the current infections that are occurring are predominantly due to the variant strain. So, it's really replaced the ancestral virus.
When did that begin? So for people listening who may have been infected, broadly, I'm obviously holding you to this, but broadly, when would the variant strain suddenly have replaced the ancestral strain?
So we started to see that around October, November. Preceding that, there were a number of other variants, the ancestral strain being the greatest. But really, we started to see that from the work of Tilly Oliveira and his colleagues, in KZN and elsewhere in South Africa. Really fantastic work, showing that there was that switch. And so really, end of last year, and by now we're really seeing, the vast majority of the variants.
And if I was worried about it, because I obviously on the line of argument you had, which I understand perfectly, if I've had the variant, I'm perhaps more protected to a second infection. Could I go and get antibodies which would show me whether I've actually had the variant or not, or is that not possible?
No, the antibody test doesn't show, it doesn't tell you whether it's variant versus, the only way of really knowing is to be able to isolate the virus, so at the time you were sick, first time you were sick, second time, and then genotyping them and showing that they were different viruses. That's really how we know what's happening. But
I suppose that on the line of argument again is that if you had the variant, if you had got COVID round about, say, the middle of November onwards, then it's more than likely than not that you would have got the variant. Beforehand, one may not be so sure.
Yeah, absolutely. Beforehand, you were more likely to have had one of the other strains.
Now, can I just ask you, just because, you when we were speaking, you said, of course, you're a clinician as well. Have we got better at treating people?
Well, yes and no. Yes, in the fact that, particularly during the first wave, we learnt a lot about about the treatment and what was required, not only from our experience in South Africa, but of course largely from experience that was being accrued elsewhere in the world, and particularly from important trials and these large trial platforms which were able to really fairly rapidly tell us what worked and what didn't work. And it was clear that some of the front runners early on, which were the sort of go-to that were on the shelf and we could try, hydroxychloroquine, azithromycin and others, really were shown to not work. Whereas interestingly, it was steroids and, oxygen, obviously we know. And these are the real old workhorse drugs. There's nothing new about these drugs, but steroids really were the first and only real treatment to be shown, proven in trials, to reduce mortality. Now, as time goes on, when you're first faced with a completely new disease or new infection in this way, and one which causes such critical illness, mortality rates, particularly in those of the sickest, the most critically ill in the ICU, intensive care units, tend to be fairly high. And that's actually what we saw. I mean, in my own hospital, Groote, the first month or two, nobody really survived. But actually, if you look over time, survival improves. Now, there are a lot of factors which play into that. And it's, in part, it's how we deliver oxygen, how we support people earlier on, and perhaps when we, understand when to take it to the ICU and intubate. But actually, things have improved, and mortality rates in ICUs have improved. And I think the critical thing, sorry, I apologize.
No, please carry on. It's always difficult when we're doing this to engage. Yeah. Please carry on.
Yeah, so I mean, what we really learned in South Africa fairly early on was that there are a subset of patients who get COVID who really get severe disease. And when I say severe disease, they require hospitalization, and then there's those that really are critical. The severe disease, oxygen is the mainstay of treatment, but until the first wave of COVID, the sort of oxygen support, the really high flow oxygen, giving large volumes of oxygen, which was needed, really was something that was only ever performed in the intensive care units. And COVID demanded of us to really change because we just didn't have, intensive care capacity to do that. So, colleagues here at Groote and elsewhere really pioneered moving these important oxygen delivery systems into general wards, which is, it is challenging. But we saw also in other countries, in Italy and elsewhere, the importance of trying to keep people off ventilators because actually, their mortality is very high. And we saw good results. So I think we've learned a lot during the first wave and indeed some in the second wave. We haven't had the miracle cures that we would like to see. And we've had further issues with, pretenders that we don't know about yet, which may be a benefit, may not. But I think, overall, as a health system and as healthcare workers, we are better at treating COVID now than we were certainly in the first wave.
So on that point, I noticed recently there was a decision, or it might well have been a settlement before the court, that permitted ivermectin to be used. Yet the preliminary studies all seem to, at best, to be ambiguous, maybe not even ambiguous. So is it advisable to use this drug?
Not on current evidence, no, absolutely not. And I think, this is a very difficult, position and a very difficult issue. It's also a fascinating case study because, ivermectin is predominantly a veterinary drug. In humans, it's used for really very specific worm infections like river blindness caused by onchocerciasis and some gut worms. And it's very rarely used, and occasionally for some skin issues. Many drugs, medicines like hydroxychloroquine, like azithromycin, like others, in the laboratory may have some action against viruses, or they may boost immunity, host immunity, but that doesn't mean that they actually work. The only way to find out if they work is to perform proper randomized control, double-blind clinical trials. And that's really been one of the lessons from COVID, the immense power of these platforms like the recovery trial platform and the solidarity trial platforms, which have given us these answers. Now, people have decided, some people have decided that ivermectin is the next great hope. But the evidence for it, the trials that have been done, have been extremely small, awfully performed, with really almost uninterpretable data. And the only one, actually, most recently, that is of any value, really shows that there is absolutely no benefit from ivermectin in reducing the passage from sort of mild to moderate disease to severe disease. So there is no good evidence at the current time that ivermectin actually has any benefit. And every medicine, including ivermectin, has potential harm. And therefore, it is, really critical that we get the data. There are a lot of clinical trials coming out. Maybe in the end, there will be shown to be a benefit. But at the moment, people are taking ivermectin to try and prevent COVID and treat COVID without any good clinical evidence.
Now, I'd love to debate this further, but I'm aware of time and I want to move on. I wonder if to move to vaccines, but my segue into that is this question, now that we're into flu season, as to whether in fact, and the question, I suspect, is people saying, well, you can't, if you get the flu injection, assuming we get vaccines, you've got to wait a fairly lengthy period before you get the vaccine. Is there truth in that?
The answer is, we don't know about the interaction. However, there's no good logic as to why there would be a problem between having influenza vaccine and a COVID vaccine. What we are generally advising is that we leave 2 weeks in between the two. And predominantly that's because, many of the side effects that occur, well, not even the side effects, many of the effects that vaccination can produce, the painful arm, the muscle aches, etc., tiredness, that are transient and are related to our immune response, can be similar. So in general, we are suggesting waiting 2 weeks. We don't know.
Moving on to the vaccines, let me ask you this. I know we're not going to get AstraZeneca, but obviously it's caused concern right across the world. This small proportion of people who get blood clots. Now, in a way, is this just a big fuss about nothing? Because I heard it said the other day that you've got more risk of actually dying if you have Rice Krispies for breakfast than you do if you take AstraZeneca. And the figures seem to show that. I suppose so there are two questions. One is, should we be anxious about this? And what effect will this have in relation to the vaccines we are likely to get, J&J and Pfizer?
So this is an extremely rare occurrence. As you said, it's extremely rare. The estimates are anything from 1 in 100,000 to even greater. So we're talking about a very rare event, which the hypothesis is that the actual delivery system, potentially the vector of the AstraZeneca, acts to cause a reaction with an antibody and the way platelets occur. So what happens is that paradoxically, your platelets, which are involved in clotting, actually reduce, but you get potentially these serious clotting events. Now, this is extremely, extremely rare. And although there is increasing understanding and probable link with the vaccine, with the AstraZeneca vaccine, this hasn't been shown with other vaccines or seen with other vaccines. None of the regulatory agencies to date has suggested stopping AstraZeneca vaccination programs. And you are, orders of magnitude more likely to die of COVID-19 than you are of a serious blood clot and this VIPIT, which is as it's named. So I think the point is that this has shown actually that the vaccine programs are working correctly, because we want to know about adverse events. You know, it's critical that these are reported and that they are questioned and looked at. But at present, there is no reason not to. Now, the countries that have halted, or particularly the UK, I think, have come out suggesting, because it looks as if, and again, you know, more data is needed to really firm this up, that it's potentially younger people that this is affecting. And in areas, in countries where there are, you know, you're spoiled for choice and you can have whichever vaccine, you don't need to give AstraZeneca. Well, maybe there, you know, those countries may decide to give the younger people in the population a non-AstraZeneca vaccine, a different vaccine. AstraZeneca vaccine is likely, or was hoped to be, the real bedrock of the global vaccination program. It's cheap, it's easy to administer. It's, you know, it doesn't require all the sort of as much cold chain as you know, other vaccines are needed. So it's a really critical part of the global response. And as I say, at present, none of the regulatory agencies, WHO or, you know, EMA, the FDA, any of them have said to stop. And so it's still critical to get, the faster you can get a vaccine into your arm, whichever it is, the better. I don't think it impacts on J&J or Pfizer or any of our vaccines. It hasn't been seen with this, but we need to see.
So before I get into delivery, one final question, Relations, because in fact it is important. Some of your colleagues, some of the colleagues that I've interviewed, your colleagues that I've interviewed, expressed the view that we made a mistake in basically rejecting the AstraZeneca, because even if it couldn't have helped with mild and moderate symptoms, it might have saved lives, and it couldn't really have hurt, save perhaps for a very, very small percentage of the population that you and I have been talking about. Do you agree with them?
Yeah, no, absolutely. I'm very much a proponent of that view, and I appreciate and understand other colleagues who've put forward the point that, you know, there isn't specific South African data on AZ to prove that it reduces severe disease. However, as I mentioned earlier, you know, the issue about protection from severe disease versus protection from mild, moderate disease is slightly different in terms of the part of the immune response that plays this. All the vaccines really are showing the same thing, that, you know, severe disease is hospitalization and death is dramatically reduced with vaccination in general, and in you know, the AZ as well. And similar platforms that the AZ use, or similar delivery systems that the AZ use, also show reduction in severe disease and death. And therefore, I think it was, yeah, extremely the wrong thing to do. I would have hoped that we would be able to vaccinate those at highest risk, the over 60s and those with comorbidities, with the AZ vaccine. And I think it was a mistake, and unfortunately, you know, in my personal opinion, it was a mistake, and I share the views of Schuur and others.
So talking about the vaccines, Mark, I know for a fact that, you know, a number of your colleagues, I don't know that you have, but a number of your colleagues have not been vaccinated, even though they're doctors who are in hospitals and so on and so forth. And that creates anxiety for all people listening to this, because the question, I suppose, is, you know, when we finally do get vaccines, and Lord alone knows when we're going to get sufficient of them, because we've been told so many stories over so many months, the question, I suppose, is, are we going to actually be able to administer these in sufficient efficiency to get people vaccinated as quickly as possible once the supply arrives? And I'm interested in your view on that, since you're in the front line.
Yes, I mean, so there's two issues, I think, to the question. I mean, the first is, you know, perhaps I thought you were perhaps talking about vaccine hesitancy even within.
Oh, I'm going to talk about that. I'll come to that. Yeah.
Okay. So, but I mean, in terms of rollout, look, I mean, like you, I would very much like to see the detailed rollout plan for phase 2 of the vaccine. You know, at the moment, through Herculean efforts by, you know, the Sisonke trial, Glenda Gray, Linda Gale Becker, and others, you know, have been fantastic in getting the Sisonke trial up and running, and we've vaccinated 280,000+ healthcare workers. Fantastic. There are 1.2 or so million healthcare workers in South Africa that, should be vaccinated. Plus there's all, the people over 60 with comorbidities, everybody who needs to be protected. And therefore we have to see a massive upscaling of our process. Now, it looks as if it's going to be with a mixture of the Johnson & Johnson vaccine and the Pfizer vaccine. And clearly the Pfizer vaccine has issues with cold chain storage, and that have been well rehearsed in the media, and that's a challenge. We do have I think I'm a great believer that South Africa is brilliant at making a plan, but I want to see that plan, and I want to see that plan and how it's going to be done. And because I haven't seen it doesn't mean it's not there, but I think it brings full circle into an issue which has been brought up a number of times. I think is the issue about transparency, and really there's a whole country waiting to understand how quickly they can get vaccinated. And yes, all of these things play into concern in the public about the vaccine in general. People get reassured by communication and understanding. And I think it's important that we do that more rapidly. But I would like to see, like you, these plans.
Well, if you don't mind me butting in, it's pretty worrying. It's one thing me not knowing, but I mean, you're a professor at at UCT, which is a preeminent medical school, and at Groote preeminent hospital. I would have thought that they would be talking to you guys, since presumably at some point you people are going to have to administer vaccines. And what I gather from you is that they haven't spoken to you.
Well, I mean, I think that's, yes. I mean, what I don't know could fill a Bible, but actually, there's a difference between implementation of these, mass campaigns, which is, it's not clear to me whether this is going to be run on a provincial level. I mean, if it is, that's going to cause its own problems, because some provinces, I think, are better equipped to be able to roll out. And so the nitty gritty of actually the rollout and how it's going to happen, and who's going to do it. You're going to need masses of people who can vaccinate. So that although we've been involved in, there is involvement in some discussions, the actual modus of this and how it's really going to happen is important for all of us to know. And we don't know that yet, and it hasn't been as transparent, I think, as it could be. We know in theory what phase 2 is going to look like. We know in theory who the people, which categories of people are going to be first in line. So although we know that, we don't know the detail, and if we're going to play a role, then we need to do so.
But just apropos that, and coming back to an earlier point you made, if we're actually presuming, as I suspect must be, that somewhere around the middle of May, June, we will be hit by a third wave. Number one, it would be rather, I suppose, very disastrous for us if we really haven't got a serious program going by then, because that makes even more people vulnerable. But could I ask this? Will it be much more difficult to be vaccinating people in the midst of a massive wave? I mean, I'm going to queue up. I mean, how am I going to do this?
Yeah, no, absolutely. I mean, in an ideal world, this is exactly the time that you want, to have everybody being vaccinated as quickly as possible, because the infection rate at the moment is very low. And you're absolutely right. If you are in the midst of a large third wave, there's a lot of people who potentially not only, of course, are going to be sick themselves and have symptoms and be isolated and therefore not be able to get to a vaccine as quickly as possible. That's one thing. But of course, we know that there are a very large percentage of people are asymptomatic. And therefore, everyone standing in the line and waiting, etc., those people, there's going to be a degree of people that will be carrying the virus and potentially be able to transmit, which makes all the public health interventions and other things and how this vaccine program is going to work so critical. And that's why, we really, I hope that behind the scenes, there's all of this has been sorted out. But I'll feel a lot more comfortable when I actually see this.
Well, I've run out of time, but I'll feel a lot more comfortable when because then I feel that at least if you and other experts like then we may know in the same time. Marc Mendelson, thank you very much. I just want to say one thing before I conclude. What really frustrates me, and let me insert my own view here, when I listen to people like you and Professor Gray and Professor Mardy, Professor Fenter, who I've interviewed, I'm stunned by the expertise we have in this country. I suppose I shouldn't be, but I am. I'm constantly, just uplifted by it. And then the frustration is, if we've got all experts like you, we should be doing a lot better, because we're not like other countries, developing countries. We really have expertise. We should be doing better. And but thank you very, very much for giving us a really enlightened view about what on earth is going on, and I'm very grateful. I suspect I might have to have you back again before this all plays out. But thank you very much, and thanks for all the work you're doing.